I'll go ahead and get started just so we can finish on time as well. So I think the main thing I want to focus on today, I'm going to try to keep it from getting too dry, but just there's been a lot of change, I think, in the stroke field in the last 20 to 30 years. I want to highlight some of that in terms of how we got to where we are today and also where we think we may be going in the next few years and try to highlight some of these things that's going to talk about. I think the story is best told through a number of the landmark trials that we've really developed in the stroke field, and that informs most of our practice in terms of what we learned during either stroke or neurointerventional fellowship. So we'll try to touch base on that without getting too bogged down in the granular details of each trial, et cetera. Hey, starting from like the 1990s or the pre-1990s are it was a little bit more of the diagnose what's going on. Emergency doctors were very good. They could tell when someone's having a stroke, but the actual options we had available, I mean, this is slightly crude, but in terms of the workflow was pretty straightforward. MRI was not prevalent. People didn't necessarily need it. They could diagnose a stroke from a head CT, and the options that people were offering while someone with an MI could get thrombolytics, eventually in a few years they'd be getting procedures. It'd be like you're having a stroke. They'd be able to give antiplatelets, and the focus was going to be on rehab, getting them a trach, PEG. Many patients are ending up in nursing home with a significant, what we call an MRSS score that we'll talk about a little bit down the line. Now, moving forward to where we are today, this is like a decision-making tree from a hospital protocol, but it's just so much more complex, which is good. It's infinitely more complex, but we also have a number of more things that we offer to our stroke patients, often resulting in a change of their life for the better and preventing them from having significant morbidity, mortality. You don't have to memorize all this, but it's just a sense of we have a number of tools in our arsenal now that we just didn't have before. So, kind of how did we get to where we are today? And a lot of this began in that 1995 era NIH-sponsored NINDS trial. We began using TPA. It took about 10 years after that we were still trying to find what the optimum window was. ECAS, the E stands for European. It was a multi-center trial. They extended that TPA window. Initially, it was only for 3 hours, but how many of our patients come in within 3 hours of onset of their symptoms? It's minimal, but people do trying to get to an ED that had thrombolytic capability. They expanded that window, got a few more patients, hyperacute treatment. Soon afterwards, our imaging improved. We were able to find out where the clot was. And, some very bright people had the idea, why don't we make devices to go after the clot just the same way radiologists do? So we began having the prototypes of forebears of devices we use now. They're called Mercy, Penumbra. We'll have a few pictures in the slides moving forward of that. Initial trials were underwhelming with the newer devices, but it was a start. The devices got innovated, private industry got involved. New trials came out 2013, 2015. Eventually 2018, we're now doing imaging criteria, or we're really picking the proper patients who could benefit from this. Our techniques have gotten better where we're not really tearing up these very small blood vessels in the brain. And now it's a matter of we've gotten to where we are today and kind of what we can do and what's left to innovate after the therapies that we have to offer. And I want to touch base on some of those. Just sort of a little bit of a timeline. Even this already, the way the stroke field is moving is almost outdated because you guys see in the bottom, they're talking about what are we going to do with distal medium vessel occlusions. And just 2 months ago at ISC, we were publishing data on, clinical equipoise. Was it beneficial? Is thrombolytics better? And that's still an ongoing debate. Just a year ago, we had some of these trials, Rescue Japan, large core. We're still innovating our own hospital policies in terms of should we go after large core infarcts? What are the benefits? How much brain tissue are we saving? And I know a lot of you guys know this, but just a quick reminder. This is the MRS scale. It goes from 0 to 6. Again, 0 is no symptoms, 6 is dead, 5 is with severe bedridden disability. And our main goal in a lot of this is just trying to avoid having people end up in this 4 to 6 area where they're continuing to live their life, being active in the 0 to 3, really, 0 to 2 if we can. Why they gave 2? They're the same thing essentially. And so starting from the NINDS trial, it was again conducted in 1995. You don't have to go into every detail of the trial, but the main thing was they had 2 points. They first want to find out, does TPA work? And the hyperacute give TPA, was there improvement in 4 points? scale. And the part two outcome was even if it works acutely 90 days out, and this is where most trials now use, this benchmark, i.e. 90 days out, what's happening to the patient? Do they have neurologic recovery? That was a part two primary measured. And we'll skip over this. It's interesting that you'll see this is a graph you're going to see commonly in the MRS scale, but it kind of looks like this was created in MS-DOS or something. And down the line, the colored graphs and stuff. But more or less, you see placebo and TPA. And the initial group here, you guys can see there's just more patients, lower MRS, fewer patients distal, the further along, because TPA seems to have some benefit. But this was given within 0 to 3 hours. Again, it's showing a benefit, but how do we get this benefit to patients within 3 hours? And not every ED has a capability to assess patients and decide that in 1995. So they start using thrombolytics. It's approved. It goes on for about 5 to 10 years, and they're really trying to figure out what is the best window to extend TPA, but also prevent bleeding. And so they do another trial into 4.5 hours, and they try to focus this just in 3 to 4.5 hours. So at the 3 to 4.5 hour window, they got a well-powered trial. There's like 821 patients, multi-center randomized controlled trial. And here you guys can see the, it's statistically significant, but it's still about 53. There's some benefit still going, and it was approved to push TPA out to at least the 4.5 hour window because we've shown benefit up to that point. This is a card that I was given in my residency to carry around. You guys probably have your stroke cards, but it just shows we're showing thrombolytics works, but how do we decide who gets it? And there's all these things that we look at: INR, do they have endocarditis, or febrile? Do they have, how often do we evaluate people with diabetic hemorrhagic retinopathy? All these things to think about, and that's really what stroke fellowship, stroke training, sometimes being stroke physician is focused on in terms of what's going on with the patient and how much benefit are they going to get. And the trials help inform too, because we know, hey, 4.5 hours has benefit, but we have fewer and fewer absolute exclusion criteria more often than not, outside of just pure blood pressure, which we can fix with blood pressure medication. If someone being on a 10A inhibitor, check the levels of those. And, things like heparin, Coumadin, we have lab work. And there's just a quick question for people just to show some of the complexity that we deal with sometimes. You have a 30-year-old female. It actually hasn't happened to me yet since I've been here, but let's say someone comes in 24 weeks pregnant. They have right-sided weakness. Remember, you can be hypercoagulable when you're pregnant. She's young, non-con head CT has a hyperdense vessel. CTA has a left M1. Last known well was 2 hours ago. So answers are a little bit lengthy, but really, would you guys say TPA? Feel free to type in the answers. Time in if you appropriate. TPA is an absolute contraindication in pregnancy because hemorrhage for fetus, the fetal demise can be significant. It should not be offered, but she should be considered for mechanical thrombectomy, M1 occlusion. Would you say TPA is a relative contraindication? Could be offered TPA, could be offered mechanical thrombectomy. Again, remembering with thrombectomy, there is radiation dose exposure. This or TPA is an absolute contraindication. Eyes, mechanical thrombectomy, also contraindication. Started on a heparin drip, taken care. You guys have an idea on what you would suggest? Yeah, a little bit of a softball, but nowadays we say yes, they can be considered for both. But always discuss the risk if you're able to. If she's, aphasic, she has a dense MCA syndrome with someone who's in there, because with someone who's making decisions for her. Because remember, it may be that the parent says, hey, we don't want to get TPA, but I want to consider her for mechanical thrombectomy, knowing that, we have pretty good reperfusion rates, so you can take out the clot. There is a clear right answer, but that's. And so now just going into what the prototypes were, some of the devices that we started. This was coming out it gained FDA clearance around 2004. There was Mercy, mechanical, and gained FDA clearance. This was a catheter with a helical coil, and it's sort of like a lance kind of injected itself into the clot and then it. One of the places where I was training had one of these. Ben, I guess the rumor was he's French, and the rumor was, he had an idea when drinking wine that the cork that went in the bottle then kind of pulled out the cork and trying to simulate that with the cork and the vessels. But it was something, and it didn't have the best reperfusion, but it did open up some vessels. Proved another device that someone made with sort of like a basket that would capture the clot. They started a prospective multi-center trial using devices. The initial trial, when they just tried to get this device to industry, like 25% achieved an MRS less than 2, not bad, but significant symptomatic ICH. It wasn't very clear that this was better than getting TPA. So someone said that we got to do a trial. We have to do a prospective randomized trial using these devices. That's well powered. 650 patients are involved in IM3. They present at 3 months in terms of results from the trial, but they still had symptomatic ICH. And I think the main thing to note, I won't belabor the point on every trial, but in these trials, they're using the Mercy and Penumbra devices. These were the first of their kind. So it was stopped early due to futility, actually. Showed no clear difference for mortality in the 90-day benchmark. Using these devices, people are having a few more complications. Even the number that are getting are still really not improving in their neural. MR rescue was in a similar vein until we get to kind of 2013. It took a few years. Private industry is more involved. This is from Stryker, and you guys might have seen this in the suite. We use the stent retriever. So the idea was this is a newer generation stent, and now you have that radial force. Clot itself kind of intercalates with the drugs on it. So you go in, you sort of get past the clot, and will enmesh itself with the clot, and then you kind of pull out the catheter and the stent, and you guys here, the clot is kind of just caught up in the struts of the stent, and this actually has better reperfusion rate. So now we found a way to open up the vessel, and it's not creating the same amount of injury with the previous device. So we're opening up the vessel with less injury. So, what's the next step? We have a new device. We're going to try to get a trial going. And just a quick review, I know a lot of you guys know this well, but remember, most of these trials were really focused on intracranial ICA, excluding the cervical ICA. M2, there's some argument in terms of what you call it, M2 in terms of it's a bifurcation, and then bifurcation, they use anatomical points, but more or less, they try to focus on the first branch off from the eye. And now we're in 2015, and we're using these newer devices, gotten away from Mercy and Penumbra, and we're trying to really use the stent retriever. Now you guys are seeing, if you take a look over here, you see there's just more people here, MRS 0, even 0 to 2 in the intervention group, and the non-intervention group increasing in that 4 to 6. And this was one of the few trials, MR Clean and Escape especially. They're using anterior circulation elbow, defined as M1, and M2, which acts on had good aspect. But remember, their time window still is only about 6 to 8 hours for this. And it's hard to catch a lot of patients. This was an international trial, and now we're really getting good. People are in the intervention arm. We're seeing a lot. This is just stats from their patients with MRI. 3% in intervention. 30%. So that's, you don't really need to do the calculations to know that 30% versus 53% is significant. 25% almost people with reduced disability that were able to go for thrombectomy. And now we're getting to the point where instead of stopping a trial due to futility, now we're stopping a trial due to early proven evidence. So really that 2013, 2015 turning point for the field. People were talking about how this was never going to launch off. Now it's like, how do we get this treatment to everyone? And really the point afterwards, we're only doing this within a certain time frame, but we want to get more and more people to be able to get this treatment. So now we start talking about trials, which you guys have heard, quoted multiple times on the stroke surface, DAWN, Diffuse 3. Remember with Diffuse 3 that there's a few criteria that we're using. It's not mentioned on the slide, but remember NIH stroke scale 6. We want to investigate thrombectomy patients in this extended window. We want to go beyond where we're going to 6 to 16 in the anterior circulation. Multi-center included 182 patients. These are some of the criteria used here. This was a little bit more imaging based. We'll talk. Labor the point, but really diffuse 3 or ICA occlusion, still using those same kind of big beefy arteries that are proximal in the anterior circulation and easy to get to. Remember, the ACAs have their own sort of twists and turns that make it more complicated. The core here is less than 70 cc. We're being generous. You're allowing an infarct core of 70 cc or less, but you still want a mismatch ratio. Mismatch ratio, Don uses clinical, we use mismatch ratio. You have a large core, but you still have a lot of penumbra. They want to use 1 or i.e. somewhere around double. If you're putting someone through that, you're at least saving something. And also they want to have a lesion. You know, you can say it's double, but if it's only 5 and 10, you know, 10 the 10 cc's is not going to, they want to get at least 15 cc's of penumbra saved in this trial, just to ensure that it gets good results, especially when you're I won't belabor the point in terms of the stats, but you guys can see it here in terms of just looking at these pictograms with the MRS. The number of people who got included for endovascular therapy did so much better than the people who didn't. You know, it's almost 26 here. Thrombectomy is statistically significant, not only in morbidity, but mortality as well. 14% in the thrombectomy went on to pass away in those 26% therapy group. So you're not only reducing disability, but it's saving lives to offer patients thrombectomy in this, you know, using the imaging criteria. This is also when RAPID came out. We didn't have that before. You know, we have an ability to look at a core, at a penumbra. We believe are stunned, but can be saved. Dawn was in a similar vein to diffuse 3. Really, the big difference is they had like these 3 stratified groups, group A, B, C. The main difference in the groups was you want to see clinical, a mismatch between the clinical and presentation measured by an NIH stroke scale and the amount of core that they had, i.e., let's say they separated by people greater than 80, less than 80. Let's say they're less than 80, on an NIH stroke scale of 10 or higher, and an infarct core volume less than 31 for those less than 80. They even allowed up to a 50 cc core, but you know, then they want a little bit higher NIH stroke scale that you're trying to make, i.e., if you have a 50 cc core, low NIH stroke scale, the stroke might have completed. You know, they didn't use the same sort of mismatch ratio. The other thing to note about this is that now we're pushing it out to 24 hours. You know, in 2015, we're at that 6 hours, 8 hours. Now we're really trying to get patients. And that captures a lot of patients. Most people present within about a day. Separating these groups out just a little bit, 6 to 12 hours, 12 to 24 hours. Still a significant difference, a little bit less, you know, after you get to that 24-hour window, there's still significant MRS 6, 40, you know, in the control group, but still had a reduction in terms of getting people over it. This is just something to note on Dawn and even diffuse 3. There's a very few things in medicine that have the therapeutic efficacy of having a number needed to treat between 2 to 3. Or functional independence, such a significant deficit, someone going from a stroke scale of like 5 or less is significant, and there's few things that are able to do that. So we want to get this therapy out. Just a quick case for review, you know, 60-year-old male, has vascular risk factors, he has AFib, not on anticoagulation, presents with onset of right side syndrome, stroke scale's 18, the vessel, you see an occlusion, you see this core, so it's a large core, it's like, you know, but there's still a significant umbra. And there's a little bit of a softball for you guys, but just to hammer in some of the points on the old trials that we had, would you guys say the core is too large? He doesn't meet criteria. I think he does meet criteria, call in the intervention. 3, core is too large. Start a heparin drip, try to get you guys have an idea on, you know, which one, Dawn or diffuse 3 he would meet? Correct, yeah, but remember diffuse 3 offered you a little bit larger core, it's 70 cc. He meets the diffuse 3 criteria. He also has that clinical ratio mismatch greater than 1. And those were some of the takeaways from those trials, i.e. we're really enrolling more people and we're giving them out. CME code one more time throughout the presentation here. And then now we're at that point where we have great treatment. We have multiple options with thrombolytics. We have thrombectomy. and we're able to offer it to patients up to 24 hours. And it's kind of like, where do we go from here? Well, we've shown anterior circulation. This is going to be beyond the scope of today. The posterior circulation, investigating, and those have actually shown positive results as well because the catheters have got. And then people are talking about, what do we do with mild strokes? Do we have anything for people beyond 24 hours? As of now, the treatments are a little bit limited in terms of acute interventions beyond 24 hours, but what about rehab options? What about regenerative medicine? Being more aggressive with it. Briefly, trials, what I think is still a work in progress. So I'll go over some of the trials that I thought were interesting in terms of large core trials and role of neuroprotective agents, which is something we're integrating a little bit more nowadays, and something I think we'll have to talk about. Policies, and this is something we discuss, the interventionalist stroke physicians, when we see someone with a large role of neuroprotective agents, and these are the trials that we invoke for that. Select two, this is someone with a 90 cc, beyond dawn. It was a randomized control trial, large vessel occlusion, still really focus on that internal carotid artery M1. The non-con head CT had to have a large 3 to 5, or an ischemic core volume 50. Some of these trials that are bunched together didn't give a ceiling on that, i.e. you could have but the main thing was EVT still had to be performed 24 hours after onset. And surprisingly, I mean, there's still a pretty significant number of people that are going to the 5 and 6. And you might expect that if someone comes in, they've been down for 4 hours, they have 100 cc core, it's going to be tough to bring them to an MRS of 0, right? Have a large core already. But I think some of this is getting into, we have reversible DWI, we get MRIs, and we compare the amount of DWI compared to this trial, again, stopped early due to efficacy because it was showing that there was less people in the MRS 6. EVT resulted in better functional outcome in days, but the only thing to note was that they had more complications. The EVT complications, access site. Patients are sick, they've been down for a while. More arterial. Mortality was similar in both, surprisingly, but there was still an improvement in the MRS despite these vaccines. More people ended up with an MRS 0 to 2 than did. They were taken forth on that with a large core. This wasn't just one trial. This was talked about at the last ISC before this. We have is here to stay, angel aspect, like the select two used a Chinese population, rescue Japan, Japanese population. China always seems to be able to enroll more patients than us. They had 456 at a trial, all with similar results, improved long-term functional outcome, but increased risk of acute vascular complications. Hyperacute, these patients were having bleeds or injuries, but I think that's also a testament to have our neuro ICU doctors here in terms of we're just managing the hemorrhages better, we're managing better. And sometimes if you do take out the clot with good reperfusion, sometimes we're able to reverse even the core aspects of DWI. One trial I'll talk about that I thought was a little bit more interesting. Nerenatide, you guys might have heard of this with the Escape NA1. Initially they tried, it was just a peptide, monkey. And it was a reperfusion, sort of invoked in these monkeys, and it was a occlusion of and they showed that in the trials, I think like rhesus monkeys and stuff are part of that family, and in their normal trials, there was significant improvement with nerenatide. This is a placebo, someone who had the clot removed, and had an injury that would be affected by stroke, but if they were given nerenatide IV along with getting reduction in T in terms of minimizing that tissue damage. So people were hopeful. They were like, hey, they got to the point where they were in trials, Escape NA1. We're enrolling patients where I was for residency, ischemic stroke with a small established for good collateral circulation. They've received a single dose of IV Nerenatide when they were thrombectomy. I think you can even run it during thrombectomy too, but it just has to be within 60 minutes of randomization. This is the inclusion criteria, similar to a lot of other trials. High enough NIH stroke scale, and carotid occlusion, endovascular treatment should be initiated within 60 minutes. And we're just checking MRS at night. Again, reviewing Nerenatide a little bit, I think that it was a peptide here. It binds a protein that helps prevent the cascade that cell death, the NMDA receptors, kind of touches this synthase. So it's a little bit of a cascade that it helps to stop these cells from dying. And it seemed to show good results again in the animal model. But when it was run on the human trial, they had these 11 patients, so well powered, but it didn't actually show statistical significance. They're like, this was when we clumped all the patients together, people who got TPA, people who went for thrombectomy. It didn't really show significant enough reduction in MRS, but then in the post hoc analysis, that people who didn't get TPA did have an improvement, got TPA, didn't. So it was interesting that people had such a significant improvement here. So people who got alteplase. So that was Nerenatide vested the people who actually didn't get TPA. So they were, for whatever reason, 4.5 hours out. People were trying to figure out why this happened. This was a little, when they ran a little bit more lab work, they're thinking that the TPA itself, tissue is a tissue plasminogen activator. Someone found that the plasmin actually acts on the protein itself. So it break apart some of the peptides that really renders this molecule inactive. So, people are more, so this was a group that didn't get alteplase. They had, improvement was suggested by the trial, but really the endpoint that was measured was that 90-day MRS. So I think there's still something to be done there, and people are talking about what's the next step. What are these neuroprotectants, and then also something to think about is these were given IV. What about intraarterial neuroprotectants? That's something that's going to prevent cell death. You guys see this on stroke service. We're starting to use things like amantadine, things that help either antagonize certain NMDA receptors. And I think there's still a lot to be done in once we've removed the clot. Now there's, I think, a significant role for beyond the hyperacute phase, rehab, still sort of tweaking and working. This was a thought that someone had in terms of a private company that stem cells. They made something called multi-stem. There's a stem cell product, Athersys company, and they're trying to give. It was a phase 2 trial called Masters. They gave IV multipotent adult progenitor cells to patients that came in with a stroke. Could be they could be admitted to the hospital. They could begin. Multipotent adult progenitor cells are kind of the beginning of cell differentiation. Lineages, kind of a bag of cells that beginning to shade. But there's still a lot of science that people progress a little more. What do these stem cells do? Is it the cytokines that they work on? Are they even able to get through the blood-brain barrier, right? They were just injected IV. They don't get through the blood-brain barrier, but do they follow like a cytokine pathway? Do they? But I think the point of the phase 2 trial, was to show, are they even safe? So the first Masters trial, dose escalation groups were given 400 million cells, 1200 million cells. So primary endpoint was kind of what they call recovery at 90. The quote from their trial here just affected direct entry and engraftment in the brain. And they don't think the cells are going in there and replacing neurons because they got or how many. Their evidence suggests that modulation. But I think at the end of the day, they don't know for sure. I think there's just something to note that treatment-related adverse events were similar in terms of no serious adverse events. Some people who got the study drug, some had fevers, chills. Everything was self. No adverse events. People quoted the conclusion was administration tolerated, but did it actually do anything? Was kind of their product that they used. Masters 2 was supposed to be a double-blind trial. They ran this in the place I was doing stroke fellowship. But it was hard to enroll people because they needed a high enough NI stroke scale, and they needed to show that there wasn't a reduction immediately. A lot of people at that time were getting thrombectomy. They had a reduction. It was a little bit insufficiently powered. The company also was going through some changes. Got brought out by like, so there was a few problems going on in terms of that. We might hear about that more, and it's going to, again, kind of what's next. There's so many areas that we want to get into now in terms of how far can we expand the therapeutic window now that we're using different thrombolytics. You guys might have seen there was a press release that T&K was just recently approved. Time is still brain, but I think there's still inter-individual ability, different collaterals, rapid progressors. You know, not everyone is the same. How many people have we seen with bilateral carotid occlusion? A lot of collateral. You know, maybe have been for more than using more imaging guidance. You guys might have heard this from some of our other physicians that came in talking about stent electrodes. We can easily get into the venous system. You can put an electrode in there, and it shows, you know, increasing that brain-computer interface for stroke recovery, press release. But I think that's a little bit more in terms of trials that we're going to see down the line, probably in the next week. Going to finish with this is the case I had back in residency. It was interesting just in terms of talking about the nuances of stroke care. It's an 85-year-old female, comes in with hypertension, diabetes, AFib, was not on anticoagulation. So they call me, I go down, we evaluate this patient. She initially was, the EMS said she had aphasia, she had a gaze preference, she had right-sided hemiparesis. She come into the ED, she's just sitting up in the bed talking, she's back to normal. Patient's stroke scale reportedly kind of 0 or 1. There was some questionable right-sided, you know, how many times have people told you there's like some flattening on the right side? There isn't a true facial droop, but that wrinkle may look a little bit different. She feels okay. She feels back at baseline. All the imaging was done because, you know, when someone comes in as these code 9s, just get everything. They got a CT, they got a CTA. But on the CTA, it looked like there was kind of an occlusion of the M1. It didn't look like ICAD and an abrupt cutoff. So people are like, well, she looks fine, but there's an abrupt cutoff on the M1. They got the perfusion as well, showed a pretty large penumbra. And so now the question is kind of what do you do for her? You guys have any ideas in terms of would you give her thrombolytic? Would you say, hey, just give her T&K and see what happens? Remember, there's a risk with T&K. We talk about anywhere from 1.5% to 3% of hemorrhage. She's totally fine right now. Or risk. You call in the team and tell them, hey, we need to go for intervention. This woman has an M1 occlusion when she's sitting up, waving at you, you know, feeling fine. Well, what do you guys think? Could you have? Yeah, it was an abrupt cutoff and there's a perfusion delay, but chronic occlusions do sometimes show, like maybe the CTA isn't always the best imaging and it looks like a cutoff, but maybe there's some flow past that. Yeah, it's a thought. Would you just admit her, give her fluids, keep the head of bed flat? Yeah, I think these were some of the steps I had. You said definitely admit, not say send her home. I'm assuming, yeah. Okay, good. Uh, Something changed, right? She had a dense MCA syndrome. Yeah, yeah, yeah. Would you send her for intervention now, like take her for angio, or remember pressure can drop sometimes and take someone for angio. And what are you gonna do? Yeah, yeah, so angio, not thrombectomy. You said just do an angio to see the vessel, but not actually go in and remove it. She's only 1 hour out, you know. Yes, Dr. Brown. That's a good question. They were watching the pressure like a hawk. It was they didn't know for sure. They had a pressure like in the field, and I think it was like somewhere in the like 160s, 170s, and then in the ED she was sitting right around there. It wasn't like 200. It was like 170s. Even I think she dropped to like 150s. It was okay. Yeah, yeah, and it's like Friday afternoon now, and it's kind of like not that the time dictates what we should do always, but it's kind of like everyone's there. We're watching her very closely. You got all the stuff. She has an M1 occlusion. She had an MCA, dense MCA syndrome. And so, I can tell you guys what ended up happening was she was admitted. There was a big conversation between the stroke team, the neurointerventional team. Some people on the side of that were like, hey, why don't we just take her now? But remember, it's an 85-year-old going through one intubation is always a risk. Two, going into a blood vessel anytime is a risk. And that can be discussed with her too. And we don't know for sure, like, Ravi was saying, what if it was like a vessel that was like maybe 50% occluded and this like plaque ruptured and then it suddenly occluded. And usually in those patients, because they were kind of half occluded, they built up this collateral tree where they have a lot of collaterals. And that was a little bit of the thought of what was going on, that she must have, she looked like she had collaterals. That was a stock footage CTA, but 5 years ago. So it was there seemed to be good collaterals there, and it was like something shut down, like some main highway shut down, and she was really getting good feeding from the detours, and she was doing well. Even when they raised her, laid her flat, they kept checking her pressure, admitted to the neuro ICU, art line was placed. She got admitted, and they actually decided they started a heparin drip because it was, I think one thought, I think giving TPA wouldn't have been incorrect as or if she's like having some fluctuating symptoms, you could say. And then um, so yeah, in terms of what happened, I see Eric here said probably both collaterals will fail. That's insightful as well, because what happened was it was actually like later. I wasn't on night float, but the night float person got called and she did decompensate. It was around like midnight, 1 a.m. She kind of went back into that MCA, dense MCA syndrome. They called the team in. The team was already kind of ready. They had a feeling something was going to happen. They had said, we just turn off the heparin drip, take her. So they took her. She got good reperfusion. She only had a mild residual deficit following the procedure. She had AFib. She was started on Eliquis. She went to rehab and did overall pretty well. But it's just interesting to think about that. I think again, just highlighting stroke care isn't just one thing for each person, and you have to really look at the imaging. We have perfusion. The perfusion helped because we could see that there was something, even in people who have ICAD, we do see a perfusion deficit sometimes, but it was just so, it was significant. You don't have the number down here, but it was like the core, that wasn't the exact one, but it was a very large core. There was a very large penumbra, I'm sorry, no core. And, the CT was clean. It looked like a hyperdense vessel, which makes you think something acutely happened because contrast is kind of collecting there. When you see a hyperdense vessel, it's like not just chronic, so there's a lot of kind of back and forth and hemming and hawing. And it's just about 8 hours later, she decompensated and they took her, and luckily she did well. But, the thinking was like, would you have just done it before? I think that was fine because even talking to the patient, she was able to make some decisions at that point. She's 85, she's fine. Um, it's risky to take anyone for a surgery, and so anything could go wrong if something is to happen in an injury in someone who is well. That's also not a good thing, and could leave her with significant morbidity if, say, the heparin drip could have just opened it up. And I think that's hopefully we're still on time. Yeah, might have talked a little bit fast, but if you guys have any questions about anything. Okay. You mean escape NA1 with the narenatide IV? Yeah. There are some trials about, I don't know one offhand in terms of neuroprotectants. People have talked about IA TPA doing targeted TPA that as of now, we had those trials at ISC, remember Angel, and some of those were positive, but that IAT and K those were positive trials where people actually removed the clot and then injected TPA. And yeah, they got good reperfusion and then injected TPA because they're thinking the distal occlusion. So there are ongoing trials about that, but not as much about, we don't have great, for whatever reason, we don't have like stem cell therapies that are great. Private companies are working on it, but remember, there's a risk, right? Stem cells are, they're progenitor cells, but they reproduce like crazy sometimes. A cancer is a risk. I think there was some talk about people having increased teratomas. You might save someone from a clot, but to cause like some sort of a brain tumor is going to be another problem, something to think about. So it's like they're still kind of tweaking what's appropriate. The neuroprotectants were relatively safe. So no, that's a good thought. Like, why not even like we get access and we're in the carotid pretty easily and that's relatively safe. Like we can actually sit at the bottom of a carotid artery and inject something without even going into the carotid artery, but because of the flow, it'll go up to the clot and it'll even go into the areas where you need to. But the only thing to think about is if the flow is arrested because of a clot, then things may not go there like you need them to. So, but we can get pretty close to those things sometimes without going intracranially. I think we still have a lot of things that we can do, and people are still investigating that. We just don't have randomized controlled trials. One, it's hard to enroll people for all this and getting the IRB approval and this and that, but things are ongoing. I think in your guys's time when you're in the attending phases, you'll probably be hearing about some of these things, I suspect. I think that's still ripe. It's just a territory we haven't explored much. We've gotten thrombectomy down, we've gotten thrombolytics down. Now it's like, what can we do? We can get a catheter in there, but there's so many things like once we're there with our instruments, like what other things can we inject? Because injecting a syringe of whatever is not that hard once the catheter is where you need it to be. It's just what you should put in there, more or less. Yes. Why do dense cores bleed? That's a good question. I think the thought mainly is that there's breakdown, such significant breakdown of the blood-brain barrier there, and such bad cytotoxic edema that it's just you're causing. It's like opening up a dam of just I think bleeding just going into that area, and there's no kind of quality control at that. Cells are dead. They're ballooning. This cytotoxic edema has occurred, and there's no change between the blood-brain barrier. So it's like dead tissue. But again, with the neurocritical care, I think the newest trials, like those large core trials, they still had bleeding. Some had what we call SICH. There's SICH is symptomatic ICH, or is it just asymptomatic ICH? And usually the trials will include SICH, i.e. symptomatic ICH is considered worse. And even people who had that did better at their 90-day. And I think that's a little bit more of us controlling blood pressure, neurocritical care, getting all the things that you need in a neuro ICU, and doing better. Down the line, a little bit of bleeding is not the worst thing. Obviously, a massive bleed that causes midline shift on top of a large stroke often is a kind of a game over, life-changing thing. But if you just have I think if you look on a 7 Tesla MRI, I suspect you're going to see petechial hemorrhage, some sort of hemorrhagic transformation on every stroke patient. Oh, can we get a set? That would be great. I think maybe where Ravi's going, NIH may have one, I heard. So yeah, you guys will. We suspect so, and that's what the large core trial showed. I mean, in terms of what you're defining a dense core, i.e., a large core with CBF, i.e., zero cerebral blood flow and the rapid, and like hypodensity on the CT. The thought is still that there is reperfusion injury, but I think the thinking is that reperfusion injury does not necessarily correlate with the worst morbidity and mortality. You do have more reperfusion injury in those patients that you take. It's just, what is your appetite for that and how much, i.e., is it blood pressure high? Is it just gushing forward and then it's, pushing all the brain structures over? Or is it just petechial, or HI2 kind of confluent image hemorrhage, which, that's something we can deal with. It's better than having the whole MCA territory knocked out on an M1 or a whole carotid territory. Most carotid occlusions have very significant morbidity mortality. So I would rather take a little bit of SICH and opening up a carotid than, having the carotid just close and, letting them complete the whole hemispheric stroke. Not that I know of. There is a trial that we may be running here. It's called STEP, where we're trying to talk about medium vessel occlusions and low NIH. But I wouldn't say there's a consensus yet because in the trials for thrombectomy, remember at ISC we did, and Hannah might have talked about this, there was clinical equipoise in terms of going after medium vessel occlusions, and those were actually higher NIH medium vessel occlusions. Those were not low NIH medium vessel, like patients with a certain NIH stroke scale greater than 6, but there was injury complications. Not only that, but just should thrombolytics be given, or are they just gonna just leave like a small M2, M3? So I think that's still being teased out in terms of how much stroke they already had, because if someone comes in with a low NIH and say an M3 occlusion, and you see sort of completed infarct, maybe you should leave that M3. We don't know for sure yet in terms of that's going back and forth. And we have a trial that we may talk about in terms of low NIH thrombectomy, because there might be other treatments that you can do for low NIH. And we're also trying to extend the thrombolytic window, a HOPE trial, things like that, we're still, I don't think it's published yet, but talking about how, who can you give thrombolytics to now that our imaging is so good? We can almost see where the clot is. We can do angios. We can maybe have more treatments in terms of maybe with tenecteplase and things, but it's still 4.5 hour is still the window. It's just, I think there's a mix, or, should we do something IA, i.e. go into the vessel and give intra-arterial T and K, but the trials again had reperfusion and then injecting T and K. So we don't have a trial that I know of where you injected T and K and just didn't go near the occlusion. So I think those are going to be a little bit, I think we're going to keep working on things like that. Yeah. So I wouldn't quite say yet that a low NIH stroke scale, unless it's like something where it's aphasia and M1 occlusion that you think is going to get worse. That I think is appropriate. But the other thing that I'll mention just with the time here, NIH stroke scale is a little bit biased in the left and anterior circulation. So some of those trials, BAO, CHE, and so these posterior circulation trials, they have low NIH, right? Someone could come in just having difficulty walking and dizziness, but they could have a basilar occlusion. And these trials are suggesting that you should go after those. So I think it's kind of patient based. So so yes and no. Some low NIH stroke scales, if it's a posterior circulation, that's a whole different game. It's anterior circulation. I think there's some nuances to it that you have to discuss, and it's not always clear that they should go for thrombectomy. Yep. Yep. Not that I know of in terms of, I don't think that more patients had to go for craniectomy that I was told. I'd have to check, like there were multiple trials like to rescue Japan. But I don't think that they had a increased risk of having to go for craniectomy, because that probably would have been reflected in the morbidity mortality. Yeah. So yeah, I think I suspect that probably less had to go for hemicraniectomy, because you opened up, usually like a large core, you opened up a large vessel and you might have had like a little bit of reversible part there. But I think again, like really the main thing that they talked about, the symptomatic ICH was there. There was some early neurologic worsening in some of those, and just axis site complications, vascular injury. But there's no not that I know of in terms of increased hemicraniectomy in the people that went for large core. Because I think if it was, I suspect it wouldn't have been positive trials. Yeah. Great. Awesome. Yeah. Thank you guys.